Good day, and welcome to today's NIC Leadership Huddle, Skilled Nursing Integration. Will COVID be the catalyst for tighter hospital partnerships? This is the sixth Leadership Huddle of our 2021 webinar series. I'm Chuck Harry, NIC's Chief Operating Officer. I have just one quick comment regarding the webinar logistics ahead of our panel's discussion. If you need to adjust your audio to today's webinar, you have joined the webinar using either your computer's speaker system or your telephone based on your audio access during your most recent GoToWebinar session. You can adjust your audio access to today's webinar through either your computer speakers or your telephone using the settings in the audio pane, which is located on the top of the control panel on the right side of your browser window. Moving to our panel discussion, it's my pleasure to introduce the host of today's Leadership Huddle, Maksimow, Senior Vice President for Kaufman Hall, a management consulting firm specializing in strategic financial planning. Andre serves a variety of healthcare organizations and has a particular expertise working with hospitals and post-acute care providers. Andre, we look forward to the panel's insights regarding these prospective partnerships.
Thank you, Chuck, and it's a real pleasure to be here with everyone. Really excited about today's panel because hopefully the audience gets real world perspectives directly from the health systems themselves that serve the skilled nursing facilities with patients. And I got really excited about hearing from each of the panelists, and we're going to hear from both the Summa health representatives and also Capital Health. Bryan will introduce his organization, and then we'll wrap it up with some information relative to recent discharge trends that we've observed for one client, and hopefully that leads into a pretty robust discussion. So I'd like to kick it off to Dr. Terpylak and Bryan Crum to introduce their organization and their current state of play.
Thanks, Andre. Mark Terpylak here. I serve Summa as our Senior Vice President of Population Health. Summa Health System is located in Northeast Ohio. We have a pretty broad geographic area that we serve. We're $1.5 billion health system. We're comprised of hospitals, ambulatory facilities, 500 plus physician multi-specialty medical group, as well as several joint ventures in home health, hospice, and inpatient rehab. We also have a provider-sponsored health plan called Summa Care. We've been in the pop health business probably for about 30 years since that plan was stood up. I would say that we've gotten a little bit more interested in population health over the last 5 to 10 years. We've been with the Medicare Shared Savings Program going back about 10 years now. We're in the BPCI Advanced Bundle Program with CMS. Conservatively, we probably have about 50,000 Medicare lives that we're bearing effectively risk on, as well as probably a comparable number of commercial lives between our provider-sponsored health plan and our other payer contractual relationships. That's a little bit about who we are as Summa Health. I'll introduce you all to Bryan Crum, and Bryan, who functions as our system director for post-acute care, can share with you a little bit about how we've built our post-acute care network and some of the challenges we faced over the last year in that network. Bryan?
Thanks, Dr. Terpylak. Hi, this is Bryan. Nice to be with you guys today. I sit on, I guess my seat on the Summa bus is right where nursing homes meet the hospital's needs. And certainly there's a misalignment in the volume-based business and the BPCI population health initiatives that the SNF and hospital are all working towards. So I sit right in the crux of that frustration, and I see the frustration on both sides, honestly. So it's really nice to be a part of this panel. But I think a great example is length of stay. When I think about some of our pain points from both sides of that fence, if you think about a hospital or a BPCI initiative striving for a length of stay of 15 days or less, and for BPCI, some of those bundles, it's certainly even shorter than 15 days. That's where we see some of that tug of war, right? For the SNF to be financially successful, that's asking a lot in some ways. And I think for the hospital, it's can we partner and get enough patients to those nursing home partners to make that a realistic goal with a 15-day length of stay or less? Because I think the SNFs need to know, come day 15, is there going to be another patient that fills that bed that's now empty for them to be financially stable? So I sit right there between both sides of that frustration, and I think we both align in the fact of can we get patients and families to select those specific facilities that we've partnered with? And that comes down to a lot of geography type questions and a lot of history questions from where I sit working with our care management folks and our discharge planners. You know, they're wanting to manage up those SNF partner facilities as that top choice to the family. But the family is saying, hey, but I have a nursing home that's just at the end of our street or just a mile up the road. So having that conversation of driving even a mile or two in a different direction or just down the road may be beneficial is some of the challenges I think we face together. And then I think we face history, which a lot of people don't think about often. But when you sit at that bedside and have the conversation about choice, and you say, we want you to go to a nursing home we partner with, nursing home X, and that family says, well, we sent dad to nursing home Y 2 years ago. Are you saying we sent him to the wrong one because now you want mom to go to nursing home X? So even history seems to play a role in some of the barriers that we're working through with our SNF partners. So that's kind of where I sit on the bus and kind of what I bring to this panel and this conversation.
Thank you, Bryan, and thank you, Dr. Terpylak, for the overview. Very helpful. And now I'd like to kick it to David Dafilou to explain his organization and what's going on.
Thank you, Andre. Good afternoon. My name's David Dafilou. I'm from Capital Health. We're located in New Jersey, central New Jersey, Mercer County. We serve both a urban and suburban marketplace. We have Trenton in our marketplace, as well as which is a very poor and underserved community in many ways, as well as Princeton and Hopewell and other markets that are very well-to-do on average. So it's a little bit diverse from that perspective. We're a 2-hospital system, about $800 million in revenue. One of the things that I would say is historically, I thought that Capital Health was very an example, very common in the hospital industry, but I think we're becoming more of a rare bird, that we're a relatively small organization, 2 hospitals. We're not a critical access facility, and we're not affiliated with a large system. So it's a little bit unique, but we're very committed to our independence and serving our region and our community. We have a large focus on our ambulatory services. We have over 400 employed physicians, about 130,000 people who are getting their primary care from these physicians in 16 primary care offices. We have several ambulatory care centers. In terms of our post-acute footprint, we don't own any post-acute care providers. We have about, in our marketplace, New Jersey is the most densely populated state in the country. So within 10 miles of our facility is over 25 SNFs, skilled nursing facilities. So we have a lot to choose from, and there's a lot of positives to that. Probably about 3 years ago, 3.5 years ago, we created a preferred network of a dozen of those facilities. And just last month, we went from that dozen down to 8 preferred facilities. And we're looking to provide, have tighter relationships, more alignment, providing medical services or oversight with physicians and nurse practitioners in some of those facilities. And certainly, the comments that Bryan made about trying to support not just our discharge planning and case management, but our population health by having appropriate discharges to excellent facilities that will help that patient across the continuum of care. So that's a little bit about Capital Health. We also are involved with several value-based programs, our commercial programs. We also are in a Medicare ACO and bundled payments as well. Thank you.
Thank you, David. And hopefully the audience appreciates the difference. Summa, more population health orientation, Medicare risk lives, about 50,000 of those Medicare risk lives. Also ownership in home health or partial ownership in home health through joint ventures and inpatient rehab. Now let's, and Capital Health being more of a smaller health system, focused on its particular region, focused on many of the ambulatory efforts, and while a little bit earlier in their journey, if you will, of value-based care. So now I'd like to kick it off to Bryan Cloch to explain his organization.
Bryan, you're muted.
Right. Yeah. Sorry. Bryan Cloch here representing Thrive Ahead. We recently, my partner and I recently developed 3 brand new skilled nursing facilities in Chicagoland area, one in the suburban Chicago, close to the city. We built it 2 68-bed, 60-unit facilities. There's some pictures on it, mostly all private suites, a couple semi-private rooms. And then we built the 3rd facility, which has, it's pretty unique. It's 3 different nursing homes really under one roof, one short-term only, one custodial long-term care, and one dementia care. That's 3 buildings, 3 separate entrances, 3 separate courtyards, 3 separate therapy spaces, virtually 3 separate facilities, but sharing one common kitchen and under one roof. It's all single story. And I'm participating on this call today really to talk about, our strategy on the short-term side. And so we've sort of built it and we hope they come. So, I probably am more interested in listening to Bryan and David and Dr. Mark talk than anybody, because we built these facilities and we're working hard to try to partner with the upstream providers to drive traffic to us. So, but that's what we're doing. And we're struggling. We're doing as best as we can, but it's been a tough market to open up. We opened up in the last 6 months, all 3 buildings. So obviously COVID hit and threw us off for a bit of a curveball. So we're doing what we can to, play with the upstream entities. But our whole strategy is to partner with the upstream entities and help them, drive their costs down, help them capture more shared savings, help them, participate in their risk-based contracts. So that's our overall strategy. So I'm looking forward to, the continued debate and discussion that we've had on these prep calls. So it should be a lot of fun.
All right. Well, thanks so much, Bryan. And now we'd like to, now that we've got the introductions down, what I'd like to do is just briefly have a touch point here relative to some of the experience that Kaufman Hall's seen relative to a client. Just to give you a backdrop, this client's about $2 billion in revenue. I would say in the early stages of its journey in terms of population health and risk-based contracting, about 22,000 Medicare and Medicare Advantage lives that they have some level of risk associated with it. And hopefully this chart is insightful. What we kind of drew here was we got a sense of what their discharge volume has been over the last, call it year during COVID. And the far left bar, if you will, represents what the average amount of discharges were to Medicare and Medicare Advantage the total volume of Medicare and Medicare Advantage. And then also the percentage designates that percentage that's been sent to skilled nursing. So what you see is about 1,800. And as you move across the bars, obviously March is when COVID hit. You see the reduction there in the overall volume, and April being the nadir, if you will. And that represented about a 54% decrease in terms of the overall discharges to skilled nursing. And you might say, well, how did that number kind of come up? it's a two-order effect, if you will, is a compounded issue. One was less volume coming out of the hospital of Medicare, Medicare Advantage discharges, and probably as important as anything else, less amount of skilled nursing going to skilled nursing versus home health. So you saw that drop down to about 23%. And then as the months went on, if you will, things have improved. The percentage of skilled nursing discharges has grown steadily over the period, but still, notwithstanding that steady growth, skilled nursing providers in the area are still faced with about a 24% reduction or 25% reduction in overall discharges. And that again has the compounded effect of A, less volume coming out of the hospital, but B, is that percentage of a rate that's going to skilled nursing is only at 27%. So there's still that gap, if you will, relative to where things were pre-COVID. And you know, the big question I'm sure audience members would like to hear is from the health system executives and get a sense of, number one, you know, where they see discharges and diversion rates to home health and or discharge rates to skilled nursing going relative to their organization, what they see in their market. So I'd like to kind of get right into it in terms of our panel discussion, and first ask Dr. Terpylak what his thoughts are relative to what he's seen in the past and where he sees the future going relative to percentage discharges to skilled nursing, and quite simply, will the volume come back? That's really the big question.
Yeah, thanks, Andre. So I can tell you that we have fundamentally shifted as a provider organization in how we view our post-acute discharge process. We historically took an approach with our transitional care coordinators and our nursing staff and our medical staff after an acute care stay. We would approach that next site of care through the lens of what level of care can we qualify somebody for. And if we can qualify them for acute rehab, that's where we took them. If we could qualify them for a skilled stay, that's where we took them. We don't do that anymore. We fundamentally ask ourselves at the time of discharge from acute care, can we send them home? First and foremost, and support them in a home environment. If we can't, then we work our way up the ladder in the other direction. That comes in large part with our movement into risk. As we become on the hook, so to speak, for the medical spend for those folks that choose us for their care, we become stewards of that spend a little bit differently, and we think about it a little bit differently. We look to our network to think and act differently as well. And it's not just, you know, in our market, frankly, it's not just us as a health system that's thinking that way. We have a lot of kind of professionalization occurring in large primary care groups. They're beginning to bear risk. And I can assure the folks that are listening in that they are every bit as focused on next site of care and trying to move people into the lowest cost site of care for all services that they are providing to all of their members that they're bearing risk for. So I don't think this is uniquely a health system initiative. This is a provider side initiative that's evolving by the day as the providers, whether they're physicians, medical groups, multi-specialty groups, groups backed by private equity, or hospitals and health systems that are all looking at this through a very different lens.
Thanks, Mark. And maybe a follow-up for you along those lines. So is it your opinion, at least in your market, it sounds like there has been this fundamental shift, if you will, in approach and philosophy. Is it fair to say then that in terms of the percentage of discharges, just the volume that's going to skilled nursing, perhaps that, you know, frankly, may not return, if you will, not so much due to COVIDs, frankly, but just different philosophies and the fact that home health seemed to be a pretty good or a high quality alternative here that's been proven out. Maybe you can comment on that.
No, I completely agree. It's not, you know, it's not because of COVID, although I think COVID certainly served as an accelerant. to kind of getting people thinking this way and approaching it differently. But as we continue to resource our capabilities in home health, and we start approaching kind of that mindset that when possible, we're not going to discharge to another facility. Whenever possible, if it serves the patient and their family well, we're going to try to get them discharged and tucked into home. And because we have our own home health agency, we believe we really can coordinate that care, support that care, and serve that patient and family ideally if we send them straight home. Now, if they're not qualified for that, then we'll send them to skilled nursing if we need to. But certainly when we make that decision to go to skilled nursing, we are looking very, very actively on an ongoing basis at who are those skilled nursing partners that share our values and are committed to providing care for those folks in the most cost-effective fashion. And it's a challenge because as Bryan Crum pointed out in the introductions, I think health systems or physician organizations that bear risk, as well as health plans that bear risk, we're not financially aligned with the typical skilled nursing operator. We are misaligned as we head down this path. And that, I think, will create opportunities for us maybe in the future to contract and or joint venture and or align in a different way than we ever have in the past when this wasn't the focus for us.
Great. Thanks so much, Mark. Maybe David, from your perspective, seeing your markets right now, I'm sure that, you know, in terms of the slide that I put up, probably those patterns look pretty familiar relative to your organization. Curious what your thoughts on are if things kind of revert back, if you will, to the pre-COVID normal, or are some of these changes going to be fundamentally instilled, if you will, in terms of care delivery?
Yeah, I don't think it'll go back to where we are. It'll be a new normal, whatever that new normal is. I think there's several things driving that. Certainly our volumes as a healthcare system are still down. So we're seeing fewer people, which is still, you know, it's surprising a year into this that people are still able to defer healthcare. So there's other dynamics that are going on there than just putting something off. And whether as a healthcare system we'll see that business come back or not is still an open question, I believe. And of course that affects downstream referrals. I think one of the things, and maybe Mark spoke to this about COVID, is it taught us, or it taught the care managers and doctors and hospitalists what can be done. We were hearing from our patients that they did not want to go to a facility. We were having problems with our facilities accepting patients because of challenges with COVID and so forth. So we were in a situation where we kept on having more and more people come in the door. We needed beds for them, and so we needed to discharge folks. So we kind of changed our mindset and said, how do we get these people to go home? And that's something that I don't think switches back as people start feeling that they can do this and seeing positive results. It makes our hospitalists much more comfortable in signing off on those discharge plans. And it's a more of a conversation that we have with the patients. And I think the patients would much rather go home in any circumstance. They didn't want to be in the hospital at all. They don't want to go to another facility when possible. They want to go home. The other thing I would say is, even though we are certainly not as far down the pathway as Summa in terms of our value-based agreements, I think that they have a halo effect. Well, we're working, as an example, on a bundle payments in neurosciences or neurology, stroke, and seizure. And we're having great impact in that area, getting more people home, having more support, doing things in the hospital that allow us to have that person go home. And it's creating a buzz in the healthcare system. So, you know, people talk to each other. So even if we have patients who are are receiving services that are not in a bundle, I think it has an impact on those also. So I think we're going to have a new normal, and I think that new normal is going to likely be less admissions for the hospital, and I think that'll even be more compounded for some of the skilled nursing in the community.
Well, thanks so much, David. So it sounds like a common theme between both the Summa folks and David is that, you know, the new normal, if you will, exactly what that volume looks like, not sure, but perhaps the diversion that's gone on with home health should probably be labeled less of a diversion, but perhaps a new world order, if you will, of what can be done in the home. You know, I want to ask Mark and Bryan this question is that, you know, given the risk that you're taking and given the fact that candidly, perhaps skilled nursing volume and even hospital volume for that matter, may be continue to go down into the future. Why is it that your organization is kind of considering at least a tighter relationship with skilled nursing facilities that you may need now versus before? You know, the conventional wisdom, at least with hospital systems, has been, you know, skilled nursing facilities, we don't need to own them. We don't need to joint venture with them. We have a preferred network. That's great. It serves our purpose. So why now think differently?
Yeah, I can lead off on the answer to that, Dr. Terpylak, and you can fill in some color commentary if you like. I think we still have a big need for right level of care at right time. And there's certainly still a place for skilled nursing, to be sure. But I think we've sent a lot of patients that could have gone to home health, to Dr. Terpylak's previous comment, to SNF in the past. So we want more patients that had been going to SNF that probably should have gone to home health, going to home health. A smaller piece of the pie, I guess, to SNF, but we still want to utilize our SNF collaborative partnerships more. So if that makes any sense, as we start to focus those referrals in tighter to that skilled nursing collaborative.
Yeah, I'll just provide a little commentary on that as well, right? I mean, historically, we were a hospital company. You know, we might have had a medical group, we had ambulatory sites, we had a health plan, but first and foremost, we were a hospital company. And the folks that work inside a hospital are facility-based. You know, one of the early things we found when we started taking risk in MSSP and in bundles and working with our M8 plan was that facility-based people are comfortable in facilities. A lot of our discharge planning was happening, was being delegated, frankly, to our therapy department. Our therapy department is facility-based. They're comfortable in a facility. So they had a bias right out of the gate to, whenever possible, if they could qualify somebody for care in yet another facility, that's where their comfort level was. They didn't really know what happened inside the home. They don't work in home care. They work in a facility. So to them, it was very natural to just kind of move from facility to facility. And we had a very kind of narrow-sighted view of what happened after folks left us. We didn't really think that much about it. And skilled nursing, to be honest, was kind of a black box. From a health system side, nobody really knew what went on over there. Folks went there, some were custodial, some seemed to come in for short-term rehab, then they moved their way out. Eventually, we hope they find their way back to their primary care doctor or their specialist, and we hope that they don't, you know, bounce back or get readmitted too soon. So it's a very fundamental shift, and frankly, I'll tell you, Andre, it was quite eye-opening as we started following our patients into the post-acute space more, and we started going into the skilled nursing facilities. And we would see our patients who were with our provider-sponsored plan, who had an M8 payer, and they had 13, 14, 15-day length of stay. And then we started following our traditional Medicare patients, our BPCI patients, and our MSSP patients into those facilities, same care teams. And they were there 28 days with the same diagnosis, the same discharge disposition, just a different pair. So it started to just kind of, you know, alert us to the fact that the financial model is misaligned as it's currently constructed as providers move into bearing risk. So I think from our perspective, it's something that we're going to have to solve. It's a riddle for us, and we need to find a different way to align ourselves with the skilled operators in our market, in our geography, that are open to partnering around different methodology, different metrics, and a different level, frankly, of care integration. And I can't stress enough, it's not just, as we've learned through BPCI, what happens during that skilled stay. It's what happens after they leave that skilled stay too, and how tightly are we integrated into that discharge out of skilled nursing? Is that handoff coming back to our home care so we can stay connected to them, or do we lose them at discharge? Do they go to some other agency where we don't have the clinicians and the connectivity, and we lose them to follow up, and yet then they readmit at day 30, day 60, all the way out to day 90 as we track them now through BPCI.
Right. That's helpful. And Mark, just to kind of think this through a little bit in terms of where your head's at, certainly skilled nursing is going to relinquish some of the admissions that it typically had before COVID to home health. But, as I kind of think about this right now for the benefit of the audience, maybe the corollary is true, meaning skilled nursing should be the beneficiary perhaps of higher cost other facility type services. And maybe if you can comment on that, but then also comment on, does the facility need to be different, if you will, to accommodate some of that higher level of care? Maybe if you can comment on those two things.
Well, yes, Andre. I mean, the short answer is yes. It works. It flows both ways, right? As we pivot our thinking away from discharging folks to the highest level of care we can, or we can qualify them for, to working that in reverse order, then where we can, we'll try to send them home and support them in that home environment. If their home is not conducive, or we don't believe we can support them in the home environment, then a skilled stay at a facility that the patient is going to want to go to, especially post-COVID, right? To some of Bryan's earlier comments about private rooms, about length of stay, about star rating, we'll send them there. But the flip side is, do we really need to send as many folks as we do now to acute rehab and to inpatient rehab facilities? No. If we have the right skilled nursing partners with the right capabilities and the right focus, and we can do that rehab in a skilled setting as opposed to in an IRF, we'll move there. No question. It flows both ways. But the net, when it's all done, there'll be more patients going home. There'll be less going to facilities post-acute, whether those are acute rehab, skilled nursing, or long-term care.
Great. So it sounds like, joint venture may be the structure, if you will, that kind of fosters, if you will, that alignment and that integration that you've had in some of your other modalities. And then in terms of, where the ultimate destination is, home is likely to be the ultimate, but then the overall overarching theme here is lowest cost of care in the highest quality site, so to speak, to get the best outcomes. That's really what I'm hearing here. And to that end, let me ask Bryan this. I mean, you're hearing Mark talk about what his situation is, and he seems to be very open right now to joint ventures and different types of relationships. So I got to ask here from the audience's perspective, why don't you call up guys like Mark and say, can we have a different relationship right now? Wondering what you think.
Yeah, I think it's all timing, right? So we laugh about this on our prep calls, but I actually probably owned the facility for a long time that Bryan referred to, that is outside the entrance or the exit and or entrance of Summa, and we bought it in hopes of connecting with Summa to do exactly what we're talking about right now. I think we bought that facility in 2003, and I think we sold it in 2009 because Summa wouldn't return our phone calls. And nobody understood at that time who we were and what we wanted to do. But we took a typical custodial facility and wanted to turn it into a short-term rehab specialty facility. And in those days, anybody we called at Summa probably didn't even understand what we wanted to do and just didn't really have any appetite for it. I think, Mark and Bryan both commented on it. I think a lot of it is just timing. No different than the Thrive facilities we just built, and we built it for specifically partnering with upstream providers. Like in our market, it's the DMG, DuPage Medical Group, it's Edward Elmer's Hospital, it's Northwestern, it's big organizations. And what we find challenging, and what I've been so impressed with listening to Summa about, is the risk-based contracts, right? A lot of the risk-taking entities don't necessarily work as hard to manage and control the risk and making those shifts. So while we deal with groups that have the risk, we've up to this point, dealt with hospital systems that literally have said to us, I'd rather gain the extra bed day and lose the shared savings from the risk contract. And that's what, as an industry, I think on the SNF side, we've built it and they're not coming because the financial strategies of the upstream providers are still trying to support the infrastructure of a hospital system when they need bed days. So, it's tough. So I think, if you get to a quality organization that's really ready to play the game or to benefit from risk contracts and to really understands the value of that to an organization, that's great. We've dealt with the advocates of the world in our market, and I can assure you that they sometimes would rather keep another bed day than, get their gain share or the risk share and what they get from shared savings. So I think we all knew a long time ago when we started talking about value-based care that this would come to a place eventually where Mark and Bryan would return my phone call. I just unfortunately don't have a building in their market anymore. So, I imagine other people after this call will call them, but they want to develop a new one. I want to get the phone call so we could build one with them and for them. But, otherwise there's probably plenty of people in their market that would want to align with them. So I think it's tough. And I think, I still say there's two things that I think about and questions that I have that I would say, right now, I will tell you, and everybody on the SNF side will tell you the same thing. We get referred a SNF patient from a hospital. We go screen them, we qualify them, we say yes to admitting them, and then we get the phone call that says, nope, they're going to IRF or they're going to an LTAC. So we scratch our heads like, how does that happen? I get paid 600 hours a day, they get paid 3,000 hours a day or 2,800 hours a day. Why would somebody pay 1,800 hours a day more for the same care? So I think that's the target that we're after. Like, we're trying to get health systems and payers and Medicaid and Medicare, somebody to pay attention, because I think while we might lose on the SNF side to home health, we should gain what's going to IRF and what's going to LTAC, because we could do exactly what they do for 60, 70% less. So the Marks and Bryans of the world that have the risk, they should want to shift that volume really quickly.
Mm-hmm. Well, you know what? And to that point here, let me just throw it back to Mark and Bryan for a second. So how do you create, or how do you kind of appropriately shift some of that volume to perhaps one or two facilities that you do have a tight relationship, or three or four, or whatever the case may be? I mean, historically, I think Bryan was mentioning before, there's a lot of challenges with geographic dispersion, geographic preferences, patient preferences over the term. And, from a practical perspective, I'm sure that many skilled nursing providers would like to do that. But the problem is, though, can you really effectively do that given the other, externalities here that you're coping with patients and otherwise? So curious what you think about that.
Yeah, Andre, absolutely. I think our IRF kind of proves that point a little bit. It's on our campus. It's very close to our main acute hospital. People seem to not be as bothered by geography because they're already there at the hospital. So going, same campus, across the street, across the alley to that location seems to be less of a barrier. So perhaps the solution is an on-campus joint venture with a SNF type. I know that's not what Bryan wants to hear. He sold that building, but I think, timing, as you mentioned, here we are, and now Pop Health is full steam ahead. So perhaps that's an option. Certainly, it's still some exploration into sharing that risk and sharing that savings with the right partner.
Okay, well, thanks very much. And David, maybe throwing it back to you. Certainly right now, capital is earlier on its journey, if you will, with population health and risk reimbursement. But from your standpoint, I guess given your markets right now, Capital Health, discharges to a variety of different skilled nursing facilities, and those skilled nursing facilities depend on Capital Health, but also other health systems in the area. From your vantage point, as this kind of becomes and evolves, maybe kind of characterizing some of the challenges you do have, perhaps keeping that volume within a tighter network, if you will, without having some of that, perhaps more of the integration that we're talking about.
Yeah, I think in our marketplace, it would be very hard for us, even with a facility on campus, obviously, since we have 2 campuses, to send everybody to 1 SNF or even 2 SNFs. I think that would be just, there's so much choice in our community, and simple little things like a bridge over a river, people want to be on one side or the other. A lot of idiosyncrasies like that, I'm sure, in every market, including ours. So we really don't see that as aligning with 1 or 2 facilities or doing a joint venture would be challenging. And we also see in other types of services, home health and other post-acute services, to the extent that Capital Health puts our brand on a post-acute care provider, some of the other facilities may be less likely to send patients there. And we have, what do we have? I guess 3, 4, if you count Pennsylvania, other acute care facilities within 5 miles of it. So that's part of the base of clients that many of these facilities have. That said, I think that there's lots of ways that we can align ourselves with skilled care facilities. We have to find the appropriate the facilities that are managed with people who are forward thinking. Certainly, many of the things that Bryan is talking about would be welcome to in our community. But we're not looking to do a joint venture per se, but we may want to have some of our physicians or nurse practitioners around at the facilities. We think that would enhance communication with our clinicians. I think that there's a number of different ways that we can create that model. But one thing that we recognize is the skilled nursing facilities are going to be looking for more volume from us. Those that step up their game to do more of what we need are going to expect something in return. It's perfectly fair, and we're actually going to find out if over the next couple of months we're able to drive more volume to the 8 facilities that remain in our preferred network as opposed to 12. It doesn't seem like a huge shift, but it'll be interesting to see how that plays out.
Well, thanks so much, David. So we're hearing kind of a tale of 2 cities, so to speak. Certainly Summa in its situation right now, really looking for more integration, more risk-based contracts, more volume we're talking about. And candidly, it's not just the care in the skilled nursing, but also line of sight after the discharge from skilled nursing, trying to get that more integrated. David, different situation, different markets, different overall population health views. And so, Bryan, just to kind of wrap it all up now, what do you kind of think about in terms of the future with skilled nursing's heading, from a custodial and or even a skilled nursing perspective? When you hear these things are changing. And if you have to take your best guess, where do you think things are going to land?
You're asking me, correct? Because it's
Yep.
Bryan. Yeah, okay. Yeah, I think there's a friend of mine that gave me a line and said that if you do something for less that somebody else does for more, you're going to be okay. So I think at the end of the day, we're going to be okay. I think there's going to be division in skilled nursing, those that do specialize in short term that can play with the Summas and the Capitals of the world, or the DMGs or the Advocates of the world, and those that do long-term custodial, that will be a different market. So I think in the end we'll be okay. I also want to get into the math. We don't have time for it. I know we're out of time, but I would challenge, the readmit rate from skilled nursing is probably in good facilities like ours, 5-6% or lower. And I'd like to understand what the readmit rate is for home health, because when you look at a 15-day stay in a skilled nursing, it's about $9,000. If you look at a home health and it's a 6% readmit rate, But if you send somebody to home health, that's probably a $4,500 episode of care cost. But if they have a higher readmission rate, from a dollar and cents perspective, 15 days is going to be a better investment than a home health visit. So I think hospitals are going to get more sophisticated. People like Bryan and Mark are going to really do the math and say, we're going to have to shift back a little bit because maybe we shifted too much. And if we've got a 25, 30% readmit rate from home health and a 5% readmit rate from SNF, there's not that much price difference between a 15-day SNF stay and a home health episode. Maybe the math's got to swing back.
I think you nailed it, Bryan. It's the total cost of care. That's the prism that's being looked at. So, sorry. So I think that we ran out of time here, but I think this hopefully was a healthy discussion for the audience to hear some of the perspectives. And Chuck, I'll throw it back to you.
Andre, many thanks for hosting today's panel discussion, and thank you to Brian Cloch, Brian Crum, David Dafilou, and Dr. Mark Terpylak for your respective insights on these joint venture partnerships and the value propositions, frankly, for both entities. As a few seats remain for the follow-up group discussion to today's Leadership Huddle webinar, if you're able to join us, you're welcome to click on the Zoom link, which is now posted in this webinar's chat. The Zoom session for the group discussion will begin shortly at 2:50 Eastern, 11:50 Pacific. We welcome everyone to join us again 2 weeks from today on Wednesday, April 28th at 2 p.m. Eastern, 11 a.m. Pacific for our next NIC Leadership Huddle, Telehealth's Tipping Point, the New Norm in Care, and How to Build for Success. The upcoming webinar will feature a conversation facilitated by Ryan Brooks, NIC's Senior Principal for Healthcare Strategy, about the value of offering telemedicine services in your business model and how to right-size a telehealth program for your organization. NIC also welcomes everyone to join us for the 2021 NIC Fall Conference, which is now scheduled to take place November 1st to 3rd in Houston at the Marriott Marquis Houston. Conference registration will open in early June. We very much look forward to seeing you there and in person. With that, we wish everyone a good afternoon. This concludes the webinar portion of today's Leadership Huddle.
Thank you.